All right, let's talk about one of those endocrine emergencies you absolutely cannot afford to miss. We're diving deep into Addisonian crisis. And trust me, this is a big one that can show up when you least expect it. Okay, so here's how we're going to tackle this. We'll start with a classic scenario, the unresponsive shock patient. Then we'll play detective and unmask the crisis, figure out why the body is failing so badly, and then, most importantly, walk through the immediate life-saving management. Let's get into it. Okay, picture this. You're in the thick of it. Your patient is circling the drain in shock. You've poured in fluids, you've cranked up the pressors, and nothing. The pressure is just stuck. What is that one diagnosis that needs to be screaming at you from the back of your mind? All right, section 1, the unresponsive shock patient. This is our starting point, a patient who is just not playing by the rules of resuscitation, and we need to figure out why fast. So what exactly is this thing we're looking for? Well, an Addisonian crisis is, to put it simply, a life-threatening endocrine emergency. It's a total catastrophic meltdown of the adrenal glands. They just quit. They stop pumping out cortisol and aldosterone, two hormones that are absolutely vital for life. This isn't just a small hiccup. It's the body's entire system going into a tailspin. Okay, so how do we actually spot this thing? Because honestly, it's a real chameleon. It can look like a lot of other bad stuff, especially sepsis. So let's put on our detective hats and start looking for the clues. You know, the tricky part is that the clinical picture can be super vague. Your patient might just complain of feeling incredibly weak and tired. They could have nausea, vomiting, and belly pain so bad you might think it's a surgical abdomen. They can be confused, even delirious. And here's a huge pitfall. They could have a nasty infection that's tipping them over the edge, but they can't even mount a fever. Oh, and don't forget to look for that classic hyperpigmentation, that sort of tanning in the skin creases. It's a dead giveaway for long-standing primary adrenal failure. But really, where the diagnosis often comes into sharp focus is with the labs. You get that blood work back and bam, you see this classic pattern. The sodium is low, the potassium is high, and a lot of the time, their glucose has tanked. This isn't just some random electrolyte mess. This is the biochemical fingerprint of adrenal failure. So let's just hammer this home. This triad is everything. You see hyperkalemia, you see hyponatremia, and you've got a hypotensive patient in front of you. An adrenal crisis has to be at the top of your differential. Seriously, burn this into your brain. It's a classic for a reason. Okay, so let's get into the why. Why does the body just completely fall apart like this? Understanding the nuts and bolts here is really what makes the treatment make sense. It really boils down to two key players, cortisol and aldosterone. Think of cortisol as the body's stress manager. It keeps your blood vessels tight, helps regulate blood sugar, and just generally handles stress. Without it, your vessels get all floppy, they stop responding to pressors, and your glucose plummets. Then there's aldosterone. Its job is all about salt and water balance. It tells the kidneys to hang on to sodium and to dump potassium. No aldosterone, you pee out all your salt and water, become massively dehydrated, and your potassium level just climbs and climbs. It's a recipe for disaster. Okay, here's a really important fork in the road. We need to know if the problem is at the factory, the adrenal gland itself, or with management, which is the pituitary gland. If it's primary failure, the factory is broken, so you lose both cortisol and aldosterone. That's why you get that super high potassium. But if it's secondary failure, the pituitary isn't sending the right signals. In that case, aldosterone production is usually okay, so the potassium might be normal, and you won't get that hyperpigmentation either. It's a crucial difference. So what's the final straw that pushes someone into a full-blown crisis? Well, look at this. The number one trigger, by a long shot, is infection or sepsis. Makes sense, right? It's a huge stress on the body. But anything major can do it. Surgery, a bad trauma, a heart attack, and a really big one to watch out for is someone who has been on long-term steroids and stops them abruptly. That can absolutely tip them over. All right, we've got our suspicion. Now it's time to act. We're shifting gears from diagnosis to management. And I mean immediate management. Every second counts here. First things first, we go back to basics. ABC, airway, breathing, circulation. But let's be specific. We're getting 2 big IVs in, we're slapping that patient on a cardiac monitor like right now to watch that potassium, and we are starting to hammer them with fluids. And we're adding a D to the mix here. Don't forget glucose. Check a finger stick immediately because hypoglycemia is a sneaky and common problem here.
And here it is, the silver bullet, the absolute, non-negotiable, most important thing you're going to do. Give 100 milligrams of IV hydrocortisone now, not after labs, not after you call endocrinology, now. This is the one move that can turn everything around, and there is absolutely no reason to delay it.
Okay, so after that initial 100 milligram bolus, the plan is pretty straightforward. You're going to keep giving hydrocortisone, usually 50 milligrams IV every 6 hours. And you keep pouring in the fluids. We're talking 1 to 2 liters of normal saline just in that first hour. These patients are incredibly dry. Now, here's a little pro tip. If you're really keen on getting a clean diagnostic cortisol level later, you can give dexamethasone instead of hydrocortisone up front. It does the job without messing up the lab test.
Now, what about that sky-high potassium? If it's getting scary, say over 6.5, or you see those classic peaked T waves on the EKG, you have to move fast. Step 1, protect the heart. Give calcium gluconate. It stabilizes the cardiac membrane. Step 2, hide the potassium. You do this with an insulin and dextrose infusion, which literally pushes potassium back into the cells. You can also add some nebulized salbutamol to help with that shift. All right, let's wrap this up by boiling it all down. Section 5, the critical takeaways. These are the things I really want you to walk away with today. Look, if there is only one single thing you remember from this whole discussion, let it be this. You have a patient in shock and they are not responding to fluids, you have to think about adrenal insufficiency. It's an absolute can't-miss diagnosis. Okay, let's quickly bust some dangerous myths. Myth 1, I should wait for the cortisol level to come back before I treat. Absolutely false. Treat first, ask questions later. Myth 2, patients with secondary insufficiency get that hyperpigmentation. Nope, that's only in primary disease. And myth 3, you always see hyperkalemia. Again, false. In secondary insufficiency, aldosterone is working, so their potassium can be totally normal. Knowing these realities can save a life. So where does the patient go from here? Well, one thing's for sure, not home. Anyone with a suspected adrenal crisis is getting admitted, period. If they're still in shock or have nasty electrolytes, they're heading straight to the ICU or a high-dependency unit. They absolutely need to see an endocrinologist. And when they finally leave the hospital, they need to go with a medical alert bracelet and their own emergency hydrocortisone kit. This is a lifelong thing. And that really brings us full circle. Look, Addisonian crisis might not be something you see every day. It's rare, but it is so lethal if you miss it. Now you've seen the pattern, you know the lab clues, and you know the life-saving treatment. So the only question left is, the next time that hypotensive patient who isn't responding comes through your doors, could you be the one to spot it?